Hello friends, welcome to my YouTube channel. This video is the last part of surgery question bank starting with appendix. Most common initiating factor in acute appendicitis is luminal obstruction. When acute appendicitis is suspected, it can be confirmed by clinical examination, USG, CT scan and also blood counts. True statement about appendicular rupture is it is common in extremes of age. It is common in people with fecalith obstruction. Appendectomy is done always in the presence of rupture. In a case of retrocecal appendicitis, extension aggravates pain. Earliest symptom in acute appendicitis is pain. When the rectum is inflated with air through a rectal tube, pain and tenderness occur in the right iliac fossa in case of appendicitis. This is known as Bastedo sign. The frequent mechanism in perforation of appendix is tension gangrene due to the accumulating secretions. Antibiotics, analgesics as well as fluids, these all are useful in acute appendicitis. Diffuse peritonitis following appendicitis is usually seen when appendicular perforation occurs early, that means within 24 hours. Rousing sign is seen in acute appendicitis. A 15-year-old boy is admitted with history and physical finding consistent with appendicitis. The positive sign is iliopsoas sign. Alvarado scoring in appendicitis includes migratory right iliac fossa pain, nausea as well as elevated temperature. Most common occurrence before appendicitis is blockage of lumen. In appendicitis, the initial periumbilical pain is eventually localized to right iliac fossa because of peritoneum. 10-horn sign is a feature of acute appendicitis. Yersinia enterocolitica produces signs and symptoms that mimic acute appendicitis. Investigation of choice for acute appendicitis in children is USG. Appendicular artery supplies only appendix. It is an end artery. Appendicular artery is a branch of lower division of ileocolic artery. Oshner-Sharon regime is used in management of appendicular mass. A 26-year-old male presented with 4-day history of pain in the right-sided lower abdomen with frequent vomiting. Patient's general condition is fair and clinically a tender lump was felt in the right iliac fossa. Most appropriate management for this case would be Oshner-Sharon regimen. Gridiron incision was first described by MacArthur. Stump size in appendectomy should not be more than 3 mm. The nerve commonly damaged during McBurney's incision is iliohypogastric. McBurney's incision is most suitable if the diagnosis of appendicitis is definite. If McBurney's incision is converted into a muscle cutting incision, it is called Rutherford-Morrison's incision. Inguinal hernia is a sequelae of McBurney's incision. A gridiron incision becomes a Rutherford-Morrison's incision, which is extended by cutting the muscles laterally. Lance incision is a muscle splitting incision. The treatment of patient with carcinoid tumor of appendix of size more than 2 cm is right hemicolectomy. Most common tumor occurring in appendix is carcinoid tumor. The diagnosis of acute appendicitis is mainly by clinical examination. USG is the investigation of choice to diagnose acute appendicitis in children. CT scan is best to diagnose acute appendicitis and appendicular lump. Blood counts also help in the diagnosis of acute appendicitis, and there is increased leukocyte count in peripheral smear. Bastedo's sign describes a condition in which if rectum is inflated with air through rectal tube, pain and tenderness occurs in right iliac fossa in case of acute appendicitis. Aaron's sign is also present in acute appendicitis and it is described as pain occurring on pressing of epigastric region. Battle sign is a feature which we see in middle cranial fossa, base of skull fracture. In this, there is bluish discoloration of the posterior part of the mastoid process. McBurney's sign is a feature seen in acute appendicitis and describes a migratory pain in patients of acute appendicitis in right iliac fossa. Rousing sign is present in acute appendicitis and described as when we present left iliac fossa in a patient of acute appendicitis, pain is felt in right iliac fossa. Iliopsoas sign is seen in patients of acute appendicitis and it is positive when patient has retrocecal appendix. When patient is asked to hyperextend the hip, patient experiences pain. Alvarado scoring is used in patients of acute appendicitis. It is used for predicting the presence or absence of acute appendicitis in patients who are suspected on clinical examination. Alvarado score consists of migratory pain, anorexia, nausea, tenderness, rebound tenderness, elevated temperature, leukocytosis, shift to left. Every character is given 1 point, only tenderness and leukocytosis are given 2 points. 10 horn sign is seen in acute appendicitis. It is on pulling the right side testis in a patient of acute appendicitis. Patient of acute appendicitis experiences pain. Investigation of choice for acute appendicitis in children is USG examination. CT scan is better than USG to diagnose appendicitis and, more importantly, to distinguish between appendicular abscess and appendicular lump. X-ray abdomen standing is used in a patient of acute appendicitis to rule out appendicular perforation. X-rays do not help in diagnosing acute appendicitis. Ochsner-Sharon regimen. It is a method of conservative management in patients of appendicular mass. The reason being, if we operate in a patient of appendicular lump, there is high chance of development of cecal fistula. Gridiron incision is a muscle-splitting incision given at the McBurney's point perpendicular to the spino-umbilical line. Gridiron incision is called as McBurney's incision or MacArthur's incision as it was first described by MacArthur. Gridiron incision is a muscle-splitting incision. If we cut the muscle fibers laterally, which are basically muscle fibers of conjoined tendon, then it is called as Rutherford-Morrison's incision. Rutherford-Morrison incision is a muscle cutting incision. Lance incision is a cosmetically preferred incision along the skin crease and it is a muscle splitting incision. It is used for appendectomy. Subcostal 11 thoracic and 10 thoracic nerves are not damaged in McBurney's incision. Iliohypogastric nerve is damaged in McBurney's incision. This can lead to formation of inguinal hernia in later stages of life. Lance incision is a cosmetically preferred incision along the skin crease and it is a muscle splitting incision. It is used for appendectomy. Kocher's incision is a right subcostal incision which is used for cholecystectomy and it is a muscle cutting incision. Rutherford-Morrison's incision is a muscle cutting incision used for appendectomy. Pfannenstiel incision is a muscle cutting incision. Carcinoid tumors are the most common malignancy of appendix. Management of carcinoid tumor in appendix is, if carcinoid tumor are less than 1 cm in size, then only appendectomy is sufficient. If carcinoid tumor is more than 2 cm in size, we have to subject the patient to right hemicolectomy. If carcinoid tumor is between 1 to 2 cm, then we have to consider the following condition, that is, if it involves the base, if it involves the mesoappendix, or if the lymph nodes are involved, we have to subject the patient to right hemicolectomy. If it does not involve the base, if mesoappendix is not involved, and if no lymph node enlargement is present, we can do only appendectomy in these patients. Adenocarcinoma also occurs in appendix, but they are not the most common tumors. Carcinoid tumors are the most common tumor of appendix and most common site which is involved is the tip of the appendix. Below the pectineal line, the lymphatic spread is to superficial inguinal lymph nodes. Internal sphincter of rectum is formed by circular muscle fiber condensation. True statement about upper half of anal canal is, this region is insensitive to pain. Anal canal is supplied by pudendal nerve. Anal canal is drained by veins forming portosystemic anastomosis. Part below pectinate line is supplied by inferior rectal artery. A patient with external hemorrhoids develop pain while passing stools. The nerve mediating this pain is pudendal nerve. In an adult male on per-rectal examination, the bulb of the penis, prostate and also seminal vesicle when enlarged can be felt anteriorly. Anorectal angulation, internal sphincter, rectal innervations, these all are important in maintenance of normal fecal continence. External anal sphincter, puborectalis and also internal anal sphincter, these all are component of anorectal ring. External anal sphincter is innervated by S2, S3, S4. Dentate line measurement from anal margin is 2 cm. Most common site of chronic fissure in ano is posterior. Percentage of GTN used in fissure is 0.2%. Conservative management, dilatation under GA, lateral sphincterotomy, these all are treatment of acute fissure in ano. Sitz bath consists of sits in a basin containing warm antiseptic solution. Rectal examination should not be done in anal fissure. Internal sphincterotomy is the treatment of choice for fissure in ano. Anal fissure best diagnosed by history and superficial clinical examination. A sentinel pile indicates fissure in ano. Most common site for anal fissure is 6 o'clock position. Commonest type of anorectal abscess is perianal. Most common cause of anorectal abscess is inflammation of anal gland. Most common anorectal fistula is intersphincteric. An AIDS patient presents with fistula in ano. His CD4 count is below 50. Treatment of choice is Seton. The treatment of choice in fistula in ano is fistulotomy. High or low fistula in ano is termed according to its internal opening present with reference to anorectal ring. Ideal investigation for fistula in ano is MRI. Solitary rectal ulcer syndrome is usually in anterior wall. It is associated with rectal prolapse. Bowel training helps a lot in solitary rectal ulcer syndrome. Most common site of SRUS is anterior 7 to 10 cm from anal verge. Treatment of solitary rectal ulcer are laxatives, rectopexy, enema. Jeeps disease is also known as pilonidal sinus. True regarding pilonidal sinus are it occurs in sacrococcygeal region, tendency for recurrence is present, obesity is a risk factor. Hemorrhoids managed by manual reduction is third degree hemorrhoid. True statements about hemorrhoids are pruritus is not common, band ligation is most commonly done after procedure, stapled hemorrhoidectomy causes less postoperative pain. External hemorrhoids below the dentate line are painful. Commonest complication following hemorrhoidectomy is urinary retention. Best investigation to diagnose piles is proctoscopy. 5 days self-subsiding pain is diagnostic of thrombosed external hemorrhoids. True statements about hemorrhoids are they are common cause of painless bleeding, they cannot be perrectally palpated, they can be banded. Internal hemorrhoids are painless and they bleed profusely. The length of standard proctoscope is 4 inches. Muscle which is primarily responsible for rectal continence is puborectalis. Above the pectinate line, lymphatic drainage is to the inferior mesenteric lymph node, and below the pectinate line, the lymphatic drainage is to the superficial inguinal lymph node. Puborectalis is a sling-like muscle which lies at the anorectal junction and form anorectal ring. Upper part of the anal canal is drained by inferior mesenteric lymph node. Upper part of anal canal is lined by columnar epithelium. Upper half of the anal canal is supplied by superior rectal artery. We can use nitroglycerin ointment and diltiazem ointment for the treatment of anal fissure. Chronic fissure is characterized by cano-shaped ulcer plus sentinel pile plus hypertrophied papillae. Anorectal ring is formed by puborectalis muscle, internal and external anal sphincter. Any fistula which opens above this is called high-lying fistula, and any fistula which opens below this is known as low-lying fistula. First investigation which we do for patients of fistula in ano is fistulogram. Best investigation available for patients of fistula in ano is MRI. Solitary rectal ulcer syndrome can present with a full thickness rectal prolapse or internal prolapse. Treatment for solitary rectal ulcer syndrome consists of non-operative therapy, surgery, and rectopexy. Non-operative therapy includes high fiber diet, defecation training to avoid straining, laxatives or enema. This is effective in majority of the patients. If non-operative therapy fails, surgery should be done. That is, either abdominal or perineal repair of prolapse is done. This is preserved for highly symptomatic patients who have failed all medical intervention. Rectopexy corrects anterior rectal wall prolapse. Banding and sclerosant injection are not given. Pilonidal sinus is a disease which leads to midline sinus formation in the lower back and coccyx region due to prolonged trauma or exposure to hairs, and it ultimately leads to a cavity which communicates with the exterior, and the tract is lined by a granulation tissue. As this is more common in males who have lot of hairs and who have jobs which involve increased friction in this area like military person or jeep drivers, it is also called as Jeep's disease. Hemorrhoids are classified into four types, that is type 1 bleeding, type 2 bleeding plus prolapse during defecation, type 3 bleeding plus prolapse with manual reposition, type 4 bleeding plus permanent prolapse. Most common complication of hemorrhoidectomy is pain, and second most common complication is urinary retention. Proctoscopy is the best investigation available to make the diagnosis of piles. 5-day self-subsiding pain is characteristic feature of thrombosed external piles. It is called so as it resolves on its own in 5 days. Anal fissure presents as pain, but it is not associated with 5-day self-subsiding pain. Fistula in ano does not present as a painful condition of the perianal region. Internal hemorrhoids are painless. Length of standard proctoscope is 10 cm, which is 4 inches. Length of rigid sigmoidoscope is 25 cm, that is 10 inches. Length of flexible sigmoidoscope is 60 cm, that is 24 inches. Length of colonoscope is 160 cm, that is 64 inches. Next is about bariatric surgery. The most effective bariatric surgery with treatment in the form of weight loss for morbid obesity is biliopancreatic diversion. In duodenal switch operation, cholecystectomy, appendectomy, jejunal-ileal anastomosis, these all are done. Patterson hernia is internal hernia occurring behind Roux-en-Y limb. Vertical banded gastroplasty is also known as stomach stapling, which is done for morbid obesity. Vertical band gastroplasty, laparoscopic adjustable gastric banding, Roux-en-Y gastric bypass, these all are restrictive surgery. Duodenal switch is not a restrictive surgery. In surgical procedure NOTES, entry point is through mouth. During laparoscopy, intra-abdominal pressure is 12 to 15 mmHg. Most commonly performed bariatric procedure nowadays is laparoscopic sleeve gastrectomy. Bariatric surgery with maximum benefits and comorbidity reduction is Roux-en-Y gastric bypass. Indications for bariatric surgery is BMI more than 40 kg per meter square, BMI more than 35 kg per meter square with at least one comorbidity, patient at high risk of obesity associated morbidity and mortality, failure of other methods of weight loss. Main side effect with biliopancreatic diversion is patient usually have an increase of 2 to 4 bowel movements per day, which in general are more malodorous, suggesting fat malabsorption. Components of duodenal switch are sleeve gastrectomy, duodeno-ileostomy, cholecystectomy, appendectomy, as well as jejunal-ileal bypass. Patterson space hernia is caused by herniation of intestinal loops through the defect between the small bowel limbs, the transverse mesocolon, and the retroperitoneum after any type of gastrojejunostomy. Stammer's hernia is internal hernia occurring through window in the transverse mesocolon after retrocolic gastrojejunostomy. Few points about laparoscopy are: needle used for pneumoperitoneum is Veress needle. Most commonly used gas is carbon dioxide. Flow of gas is 1 liter per minute. Intra-abdominal pressure is 12 to 15 mmHg. Trocar is inserted at or just below the umbilicus, penetrating skin, superficial and deep fascia, fascia transversalis, and parietal peritoneum. Post-laparoscopy shoulder pain is due to carbon dioxide retention causing irritation of diaphragm and referred pain to the shoulder through phrenic nerve. Laparoscopic sleeve gastrectomy is most commonly performed bariatric procedure nowadays. In appropriately selected patients, laparoscopic Roux-en-Y gastric bypass is most durable method of weight loss and control of obesity-related comorbidities including GERD. Bariatric operation like vertical band gastroplasty as well as laparoscopic adjustable gastric banding, these both are restrictive. Roux-en-Y gastric bypass is largely restrictive and mildly malabsorptive. Duodenal switch biliopancreatic diversion is largely malabsorptive and mildly restrictive. Natural orifice transluminal endoscopic surgery, that is NOTES, NOTES. It is an experimental surgical technique whereby scarless abdominal operations can be performed with an endoscope passed through a natural orifice, that is mouth, urethra or anus, then through an internal incision in the stomach, vagina, bladder or colon, thus avoiding any external incisions or scars. Next is about hernia. Type 3A in Nyhus classification of hernia is direct inguinal hernia. Type 7 Gilbert hernia is femoral hernia. Most common type of hernia in female is indirect inguinal hernia. A 44-year-old male undergoes a laparoscopic mesh repair for hernia. The surgical procedure is uneventful. He returns for follow-up. The wound is clean, dry and intact. The optimal convalescent period required before returning to work for this patient is 2 to 3 weeks. Triangle of doom is related to laparoscopic hernia surgery. A 3-year-old child comes with hernia of the hydrocele sac. Management will include herniotomy. Most common nerve injured in inguinal hernia repair is ilioinguinal nerve. Strangulation most commonly occurs in femoral hernia. Medial border of femoral ring is formed by lacunar ligament. In Loggius hernia, opening is in the lacunar ligament. Neck of sac of femoral hernia lies below and lateral to pubic tubercle. Hauschip-Romberg sign is seen in obturator hernia. If cecum is involved as a part of the wall of hernia and not the content, it will be known as sliding hernia. Mayo's operation is done for umbilical hernia. In Murray's classification of omphalocele, type 1 umbilical defect is less than 2.5 cm. In retrocolic gastrojejunostomy, hernia occurring through a window in transverse mesocolon is Stammer's hernia. Hernia containing Meckel's diverticulum is Litter hernia. Hernia into pouch of Douglas is Berger's hernia. True statement about epigastric hernia is it is located above the umbilicus and on either side. Regarding desmoid tumor, true statement is it is mostly females who are affected. Spigelian hernia is a type of hernia occurring at lateral border of rectus abdominis. The boundaries of triangle of Petit, the site for inferior lumbar hernia, are latissimus dorsi muscle, external oblique muscle and also iliac crust. Omphalocele constitutes a part of Cantrell's pentology. Gastrochesis mostly occurs to the right of umbilicus. Chance of associated congenital anomalies are more with omphalocele in comparison to gastrochesis. Hernia occurring through a defect in lacunar ligament is known as Loggius hernia. True statement in regard to Spigelian hernia is it presents as swelling at the edge of rectus sheath. It occurs through Spigelian fascia, which is the aponeurosis of transverse abdominis. Spigelian hernia is usually infraumbilical. For suspected strangulated femoral hernia, the least preferred route for surgery is Lockwood. Aberrant obturator artery encountered during laparoscopic inguinal hernia repair is a branch of inferior epigastric artery. During a surgery of right inguinal hernia, the operating surgeon incised the external oblique aponeurosis and opened the superficial inguinal ring. At this point, he noticed that a nerve exciting through the superficial inguinal ring and applied to anterior aspect of spermatic cord, which was inadvertently severed. As a consequence of this, the patient is most likely to have loss of sensation over the base of the penis and anterior scrotum. Nyhus classification of hernia is type 1 indirect inguinal hernia with a normal ring sac in the canal. Type 2 indirect hernia with an enlarged internal ring but the posterior wall is intact. Inferior deep epigastric vessels not displaced. Sac not in scrotum. Type 3A direct hernia with a posterior floor defect only. Type 3B indirect hernia with enlargement of internal ring and posterior floor defect. Type 3C femoral hernia, recurrent hernia. Type 4A direct hernia. Type 4B indirect hernia. Type 4C femoral hernia. Type 4D, combination of direct, indirect and femoral hernia. Most common hernia in male is indirect inguinal hernia. Femoral hernia is more common in females. Most common type of hernia in female is indirect inguinal hernia. Direct inguinal hernia is more common in the elderly. The triangle of Doom is an anatomical triangle defined by vas deferens medially, spermatic vessels laterally, and peritoneal fold inferiorly. This triangle contains external iliac artery and vein, the deep circumflex iliac vein, the genital branch of genitofemoral nerve, and hidden by fascia, the femoral nerve. It bears significance in laparoscopic repair of groin hernia. Surgical staples are avoided here. Gilbert classification type 6, pantaloon or double hernia. Gilbert classification of hernia type 7, femoral hernia. Most common nerve injured during a hernia surgery is ilioinguinal nerve. Most common nerve injured in appendectomy is iliohypogastric nerve. It increases the chance of occurrence of hernia. Treatment of choice of congenital hernia is herniotomy. Genitofemoral nerve is the most common nerve injured during Soyas H procedure. Femoral ring is the abdominal opening of the femoral canal. Boundaries are anteriorly inguinal ligament, posteriorly superior ramus of pubis, laterally femoral vein, medially lacunar ligament. Types of femoral hernia are Loggius hernia through lacunar ligament, Serophanes hernia which occurs behind femoral vessels, Thiel's hernia in front of femoral vessels, Callison-Cloquet hernia through pectineal fascia, Hesselbach's hernia occurs lateral to femoral artery, Narad's hernia occurs behind femoral artery in congenital dislocation of hip. Hauschip-Romberg sign is a sign used to identify obturator hernia. The sign is inner thigh pain on internal rotation of the hip. It can be caused by an obturator hernia. Sliding hernia is a type of hernia in which the posterior wall of the sac is viscous. In this, great care must be taken in order to avoid injury to visceral organ. It occurs in about 3% of inguinal hernia. Richer's hernia is the protrusion or strangulation of part of the intestine's anti-mesenteric border through a rigid small defect in the abdominal wall. Richer's hernia is a hernia in which the sac contains only a portion of the circumference of the intestine. It usually complicates femoral hernia. Rarely it is associated with obturator hernia. Pantaloon hernia is a combined direct and indirect hernia when the hernial sac protrudes on either side of the inferior epigastric vessels. Meidel's hernia, the hernia which contains two loops of bowel arranged like a W. The central loop of the W lies free in the abdomen and it is strangulated whereas the two loops present in the sac are not. Epigastric hernia, it is about 3% to 5% of the population, more common in men, located between the xiphoid process and umbilicus. Multiple up to 20% of patients and about 80% of the patients are just off the midline, usually within 5 to 6 cm of the umbilicus. Defects are small and often produce pain out of proportion to their size owing to incarcerated preperitoneal fat. Spigelian hernia or lateral ventral hernia is a hernia through the spigelian fascia, which is the aponeurotic layer between the rectus abdominis muscle medially and the semilunar line laterally. These are generally interparietal hernias, meaning that they do not lie below the subcutaneous fat but penetrate between the muscles of the abdominal wall. Therefore, there is often no notable swelling. Boundaries of triangle of Petit are laterally external oblique, medially latissimus dorsi, below crest of ilium. Posterior border of internal oblique muscle forms the lateral boundary of superior lumbar triangle. Hernia containing appendix as a content is Ammian's hernia. Hernia through the aponeurosis of pectineal muscle is Cloquet's hernia. Hernia associated with congenital dislocation of hip is Narad's hernia. Lockwood or low approach for femoral hernia is the simplest operation for femoral hernia. Next topic is thyroid. The occurrence of hyperthyroidism following administration of supplemental iodine to subject with endemic iodine deficiency goiter is known as Jod-Basedow effect. The lowest detection limit for third generation TSH assay is 0.04 MIU per liter. Normal thyroid weight varies inversely with dietary iodine content. Isthmus of thyroid gland overlies the second, third, and fourth tracheal cartilage. Thyroglossal cyst moves with protrusion of tongue. Sistrun's operation is the treatment of choice in thyroglossal cyst. Most common site of thyroglossal cyst is subhyoid region. Thyroglossal cyst may occasionally give rise to papillary carcinoma. Thoracic extension of cervical goiter is usually approached through neck. Thyroid storm after operation is due to inadequate control of hyperthyroidism. Propyl thiouracil is the agent of choice for treating thyrotoxicosis during pregnancy. Dancing carotid is seen in thyrotoxicosis. The best marker to diagnose thyroid related disorder is TSH. The occurrence of hypothyroidism following administration of supplemental iodine to subject with endemic iodine deficiency goiter is known as Wolff-Chaikoff effect. In thyrotoxicosis, beta blockers do not control oxygen consumption. Toxic adenoma on scanning appear as hot nodule. Graves' disease, toxic multinodular goiter as well as struma ovary. These all are conditions associated with hyperthyroidism. Papillary thyroid malignancy is common after radiation exposure. 10-year-old boy presented with cervical lymphadenopathy. Needle biopsy from the node revealed secondaries from papillary carcinoma of thyroid. The child underwent complete removal of tumor, total thyroidectomy, and radical neck dissection. The immediate next line of management is start thyroxine suppression therapy. Orphan Annie eye nuclei is seen in papillary carcinoma thyroid. Psammoma bodies are seen in serous cystadenoma of ovary, meningioma, and also papillary carcinoma of thyroid. Papillary carcinoma of thyroid has excellent prognosis. Papillary carcinoma of thyroid can be reliably diagnosed using fine needle aspiration cytology. Papillary carcinoma of thyroid typically spreads to the cervical lymph nodes. Papillary carcinoma of thyroid requires a total thyroidectomy for large tumors. Papillary carcinoma has the best prognosis. Lateral aberrant thyroid refers to metastatic foci from primary in thyroid. Cervical lymph node involvement in papillary carcinoma thyroid, best treatment is radical neck dissection. Iodine 131, that is I-131, is used in the treatment of differentiated thyroid cancer. In treatment of papillary carcinoma thyroid, radioiodine destroys the neoplastic cells predominantly by beta rays. A 21-year-old woman has 3 cm node in the lower deep cervical chain of the left. The biopsy is interpreted as revealing normal thyroid tissue in a lymph node. The most likely diagnosis is lateral aberrant thyroid. Follicular carcinoma of thyroid is due to mutation of RAS. A well-differentiated follicular carcinoma of thyroid can be best differentiated from follicular adenoma by vascular invasion. In case of adenomatoid goiter, follicular carcinoma is the commonest to occur. Lymph node metastasis is least commonly seen with follicular carcinoma thyroid. Hürthle cell tumor is follicular carcinoma thyroid. Follicular carcinoma of thyroid has hematogenous spread. Screening method of medullary carcinoma thyroid is serum calcitonin. Medullary thyroid carcinoma secretes serotonin. It has characteristic amyloid stroma. Familial medullary thyroid carcinoma may present in second decade. Age for prophylactic thyroidectomy in men 2B syndrome is 6 months. Features of medullary carcinoma thyroid are: it arises from parafollicular cells. Amyloid stroma is present on histology. 10 to 26% case of medullary carcinoma thyroid are familial. Here diarrhea occurs. In medullary carcinoma thyroid, parafollicular cells are involved. In this case, calcitonin is released. Total thyroidectomy is the treatment of choice. After thyroidectomy of medullary carcinoma thyroid, CEA is important for determining recurrence of tumor. MEN2 is seen in medullary type of thyroid carcinoma. Rett proto-oncogene defect is associated with development of medullary carcinoma thyroid. Commonest presenting complaint of medullary carcinoma thyroid is diarrhea. Anaplastic carcinoma is common in elderly. Some degree of differentiation to papillary and follicular type is seen in anaplastic carcinoma. Distant metastasis is common in anaplastic carcinoma. The treatment of choice for anaplastic carcinoma of thyroid infiltrating trachea and sternum will be palliative or symptomatic treatment. Regarding anaplastic carcinoma, true statements are: anaplastic carcinoma is common in elderly. It is associated with p53 mutation. Lymphatic spread occur here. Metastasis in thyroid gland come most commonly from carcinoma of breast. True statements about lymphoma of thyroid are: it is more common in females, clinically confused with undifferentiated tumor. Lymphoma of thyroid may present with respiratory distress and dysphagia. True statements regarding thyroid carcinoma are: medullary thyroid carcinoma is associated with MEN2A. Papillary carcinoma is multifocal. Thyroid lymphoma is often associated with Hashimoto thyroiditis. Anaplastic carcinoma occur in old age women. Low risk in carcinoma thyroid is women less than 40 years, papillary carcinoma less than 4 cm. Follicular, insular as well as anaplastic. These all are histological variant of thyroid neoplasm. Amount of iodine 131 given for carcinoma thyroid is 50 millicurie. 50, that is 50 millicurie. Thyroid carcinoma causes laryngeal paralysis due to recurrent laryngeal nerve palsy. Hypertension, episodic palpitation and also weight loss. These all are clinical features of pheochromocytoma. The investigation of choice for extraadrenal pheochromocytoma is MRI. True statement about pheochromocytoma are: 95% occur in the abdomen. Pheochromocytoma secrete catecholamines. They arise from sympathetic ganglions. Pheochromocytoma with malignant potential exclusively secretes dopamine. Commonest symptom of pheochromocytoma is headache. True statement about pheochromocytoma are: 10% are bilateral. Pheochromocytoma arises from chromaffix cells. Extraadrenal tumor shows increased noradrenaline levels. Radionuclide used in pheochromocytoma is iodine 123 meta-iodobenzyl guanidine, that is iodine 123 MIBG. The most common site of ectopic pheochromocytoma is organ of Zucker-Kandel. Good prognostic factor of neuroblastoma is hyperdiploidy. Opsoclonus myoclonus is a phenomenon seen in neuroblastoma. Diarrhea, proptosis and also bone involvement is seen in neuroblastoma. Mrs. Nina noted an abdominal mass in left side of her 6-month-old child which showed calcification near the left kidney. The cause is neuroblastoma. 20-year-old male presented with chronic constipation, headache and habitus, neuroma of tongue, medullated corneal nerve fiber and nodule of 2 into 2 cm size in her left lobe of thyroid. This patient is a case of MEN2B. MEN2A includes cutaneous lichen amyloidosis, mutation in RET in chromosome 10, adrenal adenoma. The most common organ involved in MEN1 is parathyroid. An infant is diagnosed with MEN2B trait. The best line of management is prophylactic surgery. Thyrotoxicosis factitia is defined as occurrence of hypothyroidism due to external supplementation of thyroxine. D. Quervain's thyroiditis is a type of thyroiditis which occurs due to viral infection. Medullary carcinoma of thyroid arises from C cells of thyroid. It has no relation to thyroglossal cyst. Hyperthyroidism is most difficult to control in the first trimester of pregnancy and easiest to control in the third trimester. Both thyrotoxicosis and malignant hyperthermia may cause myopathy, but in hyperthyroidism, serum CPK is often normal. Lateral aberrant thyroid refers to a condition where there is lateral neck swelling and when biopsied it shows thyroid tissue. Most common cause is a spread of the tumor from the primary thyroid malignancy. Most common malignancy responsible for the lateral aberrant thyroid is papillary carcinoma thyroid. 99M technetium is used for the bone scan, but it is not used for thyroid scan as it is not taken by the thyroid tissue. It can help in making the diagnosis of bony metastasis in thyroid cancer. P32 and iodine 131 MIBG is not used for thyroid scan as they are not taken up by the thyroid tissue. In Hürthle cell tumor, we have a characteristic Hürthle cell or Ashkenazi cells. Metastatic tumors of thyroid is rare. Most cases are found in autopsy. Most common site of primary is carcinoma breast more than carcinoma lung. If thyroid metastasis is detected pre-mortem, most common site of primary is renal cell carcinoma more than carcinoma breast more than carcinoma lung. Investigation of choice for extra-adrenal pheochromocytoma is MRI. MRI is the investigation of choice for adrenal extra-adrenal pheochromocytoma and in pregnancy. Pheochromocytoma follows 10% rule which indicates 10% bilateral, 10% malignant, 10% occur in pediatric patients, 10% extra-adrenal, 10% familial. Chronic watery diarrhea, which is due to the secretion of VIP, and opsoclonus myoclonus, that is dancing eyes or dancing feet. These all are unusual paraneoplastic manifestation of neuroblastoma. Neuroblastoma presents as stippled calcification on CT scan. Ganglioneuroma is a feature of MEN2B syndrome. Cutaneous lichen amyloidosis is a feature of MEN2A syndrome. MEN2A syndrome is caused by the mutation in RET oncogene cysteine codon which presents on chromosome 10. MEN2A is associated with adrenal adenoma. Most common organ involved in MEN1 syndrome is parathyroid gland and the most common manifestation is parathyroid adenoma. Defect of MEN2A is RET oncogene chromosome 10 of the cysteine codon. MEN2B defect is RET oncogene of chromosome 10 of tyrosine kinase domain. MEN2A components are medullary carcinoma thyroid, pheochromocytoma, parathyroid hyperplasia or adenoma, Hirschsprung's disease, cutaneous lichen amyloidosis. Components of MEN2B syndrome are medullary carcinoma thyroid, pheochromocytoma, intestinal ganglioneuromas, mucosal neuromas, megacolon, marfanoid features. Next topic is breast. Risk factor for carcinoma breast include nulliparity, family history, estrogen, OCP, BRCA1 mutation. Epithelial hyperplasia is a predisposing factor for carcinoma breast. BRCA1 positive women have 40% increased risk of breast carcinoma. Gale model of risk assessment is used for carcinoma breast. Lung cancer is least associated with genetic and familial cause. Types of fibroadenosis most likely to undergo malignant change is epithelial hyperplasia. Risk factor for carcinoma breast is sister died from cancer. Risk factor for carcinoma breast includes early menarche, late menopause, ovarian cancer. In ductal carcinoma in situ, comedo growth pattern is seen. Bilateral multicentric types of carcinoma in breast is usually invasive lobular carcinoma. True statement about histology in infiltrating lobular breast carcinoma is single file or pattern. Carcinoma breast is most commonly seen in upper outer quadrant of breast. Nottingham prognostic index for carcinoma breast is I equal to 0.2 into size plus grade plus nodes. Rare histological variants of carcinoma breast with better prognosis include mucinous carcinoma, medullary carcinoma, tubular carcinoma. Histological variety of breast carcinoma with best prognosis is tubular. In lobular carcinoma of breast, biopsy of the opposite breast is advised. Group of lymph node involved in breast carcinoma are supraclavicular, axillary and also internal mammary. PUD orange is due to blockage of subdermal lymphatics. Most common type of breast carcinoma is invasive ductal carcinoma. Carcinoma breast is least commonly seen in lower inner quadrant. Nipple inversion occurs due to involvement of subareolar duct. Van Nuys grading system is used for DCIS. Triple assessment for carcinoma breast includes clinical examination, mammogram, and FNAC. Best diagnostic method for breast lump is biopsy. A 45-year-old woman presented with hard and mobile lump in the breast. Next investigation is mammography. Investigation of choice for high-risk breast cancer in female is MRI. Most sensitive imaging for ductal carcinoma in situ of breast is MRI. BIRADS stands for Breast Imaging Reporting and Data System. Indicators of malignancy in a mammography include speckled margin, attenuated architecture, irregular mass. A 55-year-old post-menopausal woman on hormone replacement therapy presented with heaviness in both breasts. A screening mammogram reveals a high-density speculated mass with cluster of pleomorphic microcalcification and ipsilateral large axillary lymph nodes. The mass described here most likely represents carcinoma. Carcinoma breast stage T4B involves skin ulcer over the swelling, dermal edema, satellite nodule. 4 cm breast nodule with ipsilateral mobile lymph node in axilla staging is T2N1M0. Breast mass of 6 into 3 cm size with hard mobile ipsilateral axillary lymph node and ipsilateral supraclavicular lymph node. The stage of breast cancer corresponds with the following case is T3N3M0. In patient with breast cancer, chest wall involvement means involvement of any one of the following structure, that is serratus anterior intercostal muscles and also ribs. True statement about modified radical mastectomy is pectoralis minor is divided. Breast conservation surgery includes lumpectomy, radiotherapy, axillary lymph node dissection, sentinel lymph node biopsy. In radical mastectomy, pectoralis major, pectoralis minor and axillary lymph node is removed. Drug used in estrogen-dependent breast cancer is tamoxifen. Components of CODS are quadrantectomy, radiotherapy, axillary dissection. Use of tamoxifen for breast cancer can cause thromboembolism, endometrial carcinoma, cataract. Superolateral boundary of axillary dissection is axillary vein. A 50-year-old female has undergone mastectomy for carcinoma breast. After mastectomy, patient is not able to extend, adduct and internally rotate the arm. Now supply to muscle is damaged. The muscle which is affected here is latissimus dorsi. In Patty's mastectomy, the step done is nipple and areola is removed, surrounding normal tissue of tumor is removed, pectoralis minor is removed. Malti, a 45-year-old female patient with a family history of breast carcinoma, showed diffuse microcalcification on mammography. Intraductal carcinoma in situ was seen on biopsy. Most appropriate management is simple mastectomy. For carcinoma breast, best chemotherapeutic regimen is cyclophosphamide, methotrexate, 5-fluorouracil. Breast conservative surgery is indicated in young patients, ductal carcinoma in situ and also infiltrative ductal carcinoma. Absolute contraindication of conservative breast cancer therapy is history of previous radiation, first trimester pregnancy. In breast conservation surgery, the healthy margin excised is typically 1 cm. Treatment of hormone-dependent fungating carcinoma of breast with secondaries in the lung in a female patient aged 30 years is simple mastectomy followed by oophorectomy. Distressing complication after modified radical mastectomy is lymphedema. Complication of post-mastectomy lymphedema is lymphosarcoma. Pain along medial aspect of arm in a post-mastectomy patient is due to intercostobrachial neuralgia. The most important prognostic factor of carcinoma breast is lymph node stage. Prognosis of breast cancer depends mostly upon axillary lymph node status. Good prognostic marker in breast cancer is ER positive, PR positive. Molecular classification of breast cancer is based on gene expression profiling. True statement about breast cancer in pregnancy is it occurs in 1 of every 3,000 pregnant women. Most common non-gynecological malignancy associated with pregnancy. Ductal carcinoma is most common type, accounting for 75 to 90% of breast cancer in pregnancy. Fibroadenoma of the breast are solitary mobile mass. Regarding cystic disease of breast, aspiration is the treatment of choice. Treatment of cystosarcoma phyllodes in young women is wide excision with a margin. Cystosarcoma phyllodes is usually bulky and may fungate through the skin. True statement about cystosarcoma phyllodes is calcification is present here, cystic component and also tendency to recur. Paget's disease of breast, true statement include intraductal carcinoma, mastectomy is needed here. Paget's disease of breast may have an underlying palpable mass. Paget's disease may have underlying carcinoma. Characteristic feature of Paget cell is abundant clear cytoplasm. True statement about Paget's disease of breast include it has poor prognosis, hormone receptor is negative, wedge or punch biopsy taken from nipple for diagnosis. Paget's disease of nipple, Paget's disease of vulva, Paget's disease of region. These all have underlying malignancy. Gynecomastia may be seen in Klinefelter syndrome, cirrhosis of liver, cryptorchidism, sex cord tumor of Sertoli cells. An adolescent boy presents with bilateral prominence of breast and wants the breast to be removed. Here the incision which is ideal is incision along the areolar margin. Treatment of choice in duct papilloma of breast is microdocectomy. Treatment for duct ectasia is Hadfield's operation. Sign seen in large duct papilloma is nipple discharge. A lactating female presented with breast abscess. Most common organism responsible for her mastitis and abscess formation is Staphylococcus aureus. Hansen's sign of inoperability of carcinoma includes edema of skin of breast or arm, satellite tumor nodules on skin of breast, proved supraclavicular or distant metastasis, inflammatory carcinoma. Unilateral amastia is associated with 90% of the time with absence or hypoplasia of pectoral muscle. True statement about leiomyosarcoma breast is it is well encapsulated. Mastectomy is mainstay treatment. Zaska's disease is common in smokers because it can cause chronic areolar abscess. A lady of 35-year-old lactating mother presented with painful breast lump. Most appropriate initial investigation should be ultrasonogram. Intraoperative sentinel lymph node detection in axilla is done by using isosulfan blue dye. Sentinel lymph node biopsy in carcinoma breast is done if breast mass is palpable but no lymph node palpable. Risk factors for breast cancer include age, that is, incidence increases with age, country of birth more common in Western countries, family history and genetic risk factors, that is BRCA, hyperestrogenemia, which includes early menarche, late menopause, nulliparity, obesity, late first full-term pregnancy, alcohol and high-fat diet, personal history of malignancy, that is contralateral breast cancer plus or minus ovarian and endometrial cancer, previous benign breast disease, high socio-economic status, radiation exposure, hormone replacement therapy. Gale model is the most frequently used model to assess the risk of breast carcinoma. It includes age at menarche, number of breast biopsies, age at first live birth, number of first degree relatives with breast cancer. DCIS includes subtypes like papillary, cribriform, solid and comedo. In lobular carcinoma, we get an Indian file pattern which is also known as single file pattern. It basically denotes back-to-back lining of the cell arrangement in lobular carcinoma patients. Pudy orange is due to cutaneous lymphatic edema where the infiltrated skin is tethered by sweat ducts. It cannot swell, leading to an appearance like orange skin. It occurs due to obstruction of subdermal lymphatics, that is, lymphatic permeation by tumor cells. It is seen in advanced breast cancer, which may be seen in chronic abscess. Retraction of nipple is due to fibrosis in and around subareola. Retraction or dimpling of skin is due to involvement of Cooper's. Pudy orange is due to blockage of subdermal lymphatics. Best diagnostic method for breast lump is biopsy. Tissue diagnosis is the best method to reach the diagnosis of breast carcinoma. BIRADS consist of 7 readings or gradings ranging from grade 0 to 6. Grade 0 is incomplete investigation, grade 1 negative, grade 2 benign, grade 3 probably benign, grade 4 suspicious, grade 5 highly suspicious of malignancy, grade 6 biopsy proven breast carcinoma. Boundaries of axillary dissection are superior and superolaterally axillary vein, laterally thoracodorsal pedicle, medially Halsted or costoclavicular ligament, inferiorly angular vein. Contraindication of sentinel lymph node biopsy in carcinoma breast is palpable lymphadenopathy, prior axillary surgery, chemotherapy or radiotherapy, multifocal breast cancer, metastatic disease. Haygensen's criteria of inoperability include extensive edema of breast, satellite nodule, inflammatory carcinoma, distant metastasis, supraclavicular metastasis, edema of arm, a parasternal tumor indicating spread to the internal mammary lymph node. Amasia means congenital absence of breast which may occur on one or both sides. Amasia is sometimes associated with absence of the sternal portion of the pectoralis major, that is Poland syndrome. It is more common in males. Treatment of breast leiomyosarcoma is simple mastectomy, which is the gold standard treatment. Axillary lymph node dissection is not indicated. Post-operative radiation may be used in patient undergoing mastectomy because chest wall recurrence are observed. In the starting of this video, I just told that this is the last part of surgery question bank, but I couldn't complete this because on August 30th my father passed away, so I couldn't complete this part. So again 4 or 5 topics are remaining in this surgery question bank, like liver, portal hypertension, gallbladder, bile duct, pancreas, as well as urology and testicular tumors. So with all these topics I will be putting a video like next part. So please revise all these question bank.